I'm Dr. Robert Beasley, Section Chief of Vascular Interventional Radiology, Director of Wound Care at Mount Sinai Medical Center on Miami Beach. I'd like to thank Dr. Craig Walker for the invitation to speak today at the NCVH Digital Education Series. My topic today is an overview of Lutonix data, superficial femoral artery, popliteal artery, and infrapopliteal vessels. There's a full clinical program, a spectrum of DCB utilized in the Lutonix entire program, a plethora of information. We're starting with the Levant 1 trial, which was a randomized controlled trial. Levant 2, randomized controlled as well, with the continued access. Levant Japan, also randomized controlled trial, with the same being for the in-stent restenosis trial. As far as registries go, Long Lesion Registry, Global Registry, and the SAFE DCB Registry as well. And of course, there's the below-the-knee IDE randomized controlled trial, as well as the studies on the AV fistulas. If you add all these together, the number of subjects looked at is close to 4,000, with 3,441 being DCB patients and 572 plain old balloon angioplasty. And as you can see over here, this full program has expanded and gone outside the US into Europe and Japan, with the follow-up time being anywhere from 2 years to 5 years. Take a look at the overview of the Lutonix safety data. Very important at this time. Look at the mortality risk through 5 years. Levant 1, Levant 2, and Levant Japan had over 1,093 DCB patients. Mortality was reduced as more patients were added. And if you took a look at the hazard ratio with no adjustment at 5 years, essentially they were the same, with 86.5% of the folks surviving in the PTA arm and 84.5% in the DCB arm. If you adjusted the propensity using stratification, you had very similar types of findings here with a hazard ratio of 1.16. So there was no significant increase in the hazard ratio for mortality in any analysis of Lutonix 035 DCB patients, or trial rather. There was no plausible mechanism for mortality or evidence of paclitaxel causation. And there was no increase in mortality with added additional exposure to paclitaxel in both cohorts, either the DCB or the PTA. That means that the Lutonix system continues to offer meaningful benefit relative to risk in patients with PAD. As far as the update of the Lutonix SFA Global Registry, a total of 691 patients were enrolled in Europe, and this is the proportions relative to the countries. The data was real world with all comers, multiple sites. You can see over here on the pie chart on the left, and enrollment was from December 2012 through July 2014. If you take a look at the safety, which was the absence of device or procedure-related death, TVR, or major amputation, at 12 months, there was freedom from this particular factor at 92.1%. And then at 24 months, 86.7% of the patients also had freedom from any of the major safety factors. If you take a look at TLR-free survival, the same registry, at 12 months, 94.1% had freedom from TLR. And then at 2 years, 90.3% of the patients still had freedom from target lesion revascularization. In summary of this SFA real world registry, demonstrated the durable benefits at 24 months for the Lutonix DCB in real world patients. And the registry also reinforces the safety of the Lutonix drug-coated balloon. Taking a look below the knee, the Global BTK Registry is a prospective multi-center single-arm registry. The objective was to demonstrate safety and assess the clinical use and outcomes of the Lutonix DCB for treatment of stenoses or occlusion of native below-the-knee arteries in a real-world patient population. There were 371 Subjects enrolled at up to 26 international sites. Rutherford classification was 3 to 5. You had to have at least a 70% stenosis in the target vessel, and the target vessel had to reconstitute at or above the ankle. Neurotrophic ulcers or heel pressure ulcers were excluded. Primary endpoints: safety, freedom from below the knee, major adverse limb events, or postoperative death at 30 days, and efficacy, freedom from TLR at 6 months. The follow-up was 1, 6, 12, and 24 months. These are the study centers involved in the below the knee registry. And a summary of the current 24-month data shows freedom from reintervention for distal embolization at 100%, freedom from TLR 78.9%, freedom from major amputation 93.4%, 59.5% improved by at least 3 Rutherford categories, and freedom from all-cause death was 80.5%. As far as the Lutonix Btkide IDE randomized control trial study, the device was the Lutonix 014 drug-coated PTA balloon, active drug paclitaxel at 2 micrograms per millimeter squared, the carrier polysorbate and sorbitol. The design was a prospective, multi-center, randomized, single-blinded study. Randomization scheme was 2 DCB to 1 PTA. Patients, core lab, and CEC were blinded. And the independent analysis, we had angiographic and radiographic assessment with Symbicor, duplex ultrasound evaluation, VASCOR, a CEC and data monitoring committee also assessed adverse events and patient safety. These were the study investigators and study sites, again, 51 USA, Europe, Canada, Japan, and Australia. The results, safety results, freedom from major adverse limb events and postoperative death was non-inferior between the groups, so really 99.3% for the DCB and 99.4% with the PTA. This was analysis at 30 days. The efficacy, which was analyzed at 6 months, consisted of primary patency and limb salvage. So the composite of primary patency and limb salvage was 10.5% greater for the DCB group than for the PTA group. And that was at 6 months. Looking further, efficacy observations through 12 months, composite primary efficacy endpoint and freedom from CD-TLR remained greater in the DCB group from 6 to 12 months by Kaplan-Meier analysis, converging at 365 days. Cumulative TLR rate was 2 times greater in the PTA group than in the DC group at 6 months. These converged, but still numerically favored the DCB group at 12 months. Although there were observed differences between groups and other secondary outcomes, i.e. TBI scores through 12 months, there was no statistical differences between the groups. Safety at 3 years, it was comparable between the groups at 3 years. Freedom from all-cause death, hazard ratio was 1. Major amputation rate, hazard ratio 0.81, and amputation-free survival, hazard ratio was 1. So the first look at the 3-year efficacy data revealed that there was really no statistical difference between the groups at 3 years. So the summary of the entire Lutonix clinical program: no significant increase in the hazard ratio for all-cause mortality in any Lutonix SFA Poplitela analysis through 5 years. The global SFA registry demonstrated durable benefits at 24 months in real-world patients and reinforced the safety of the Lutonix DCB. Freedom from TLR was 90.3%, and absence of device or procedure-related death, TVR, or major amputations, 86.7%. The comparable safety between the groups in the BTK IDE study was seen through 3 years, and that, again, was freedom from all-cause death, major amputation, and amputation-free survival. And at 2 years, freedom from TLR was 78.9%, and freedom from all-cause mortality was 90.5% in the Lutonix Global BTK Registry. Thank you very much for your attention.